Hi, hello, welcome back. Today, I would like to share an interesting case of serous cystadenoma of pancreas with you. This is the axial contrast CT sections of abdomen, arterial phase. I'm showing you single phase actually. Here you can see at the pancreatic level, you're able to appreciate at the head and uncinate of pancreas, there is a large cystic lesion. You may not be able to appreciate very tiny septa. However, on photovenous, they were appreciable. You can also see peripheral vessels are coursing and draping the lesion. And there is again mesenteric artery with some arteriomatous changes. Here in the center of the lesion, in plane also we have confounded. This is a central calcification. Here the ductal dilatation was not very marked in our case. Normally, we appreciate ductal dilatation more in case of mucinous tumors. In our case, there is very little or no ductal dilatation. So this is more in favor of a serous cystadenoma. The pancreatic tail and body appears atrophied. However, there is no evidence of any ductal dilatation. And calcification again is very important point to identify a serous cystadenoma. So rest of the abdomen was unremarkable. There were no lymph nodes or any metastasis in the solid organs. So just as an academic interest, we have performed MR again in this case. You can see some amount of stranding caudocranially. The septa and the microcystic appearance is very well appreciable on MR compared to the CT sequence, CT contrast sequences. So MR is helpful in identifying serous cystadenoma better than CT. However, CT central scar and calcification can be seen. Central scar and calcification. This is coronal MR sections. You can appreciate subtle ductal dilatation, central calcification, and radiating polycystic or microcystic variation, stellate shaped lesion in the head region of pancreas. So this is a classical serous cystadenoma. Now, most common and close differential diagnosis mucinous neoplasm, which is again a predominantly it won't show so many septa within. Mucinous neoplasm shows few septa, and again duct dilatation will be marked in case of mucinous neoplasm. The age of presentation is generally old age. We call it as grandmother's age of presentation is old age. We call it as grandmother's pancreatic neoplasm. There are mostly three subtypes of it: polycystic, macrocystic, and you can also see honeycombed or oligocystic variant. Cysts are separated by fibrosepta, which were appreciable on T2, as you saw in our case. Central scar with or without calcification can be present. Again, CT can help us characterizing honeycomb pattern better than MR. And very rarely, because the septa are so thin and so closely packed, even on USG or even on CT, sometimes it may mimic a solid mass because of enhancing septa. So as I said, MR is helpful in such cases. So last but not the least, how will you differentiate IPMN, intraductal papillary mucinous neoplasm, from the microcystic variant of serous cystadenoma? So ductal dilatation is present generally in IPMN, either side branch or main branch. There will be dilatation of duct in IPMN. However, the ductal dilatation is generally absent in serous cystadenoma. Calcifications are absent in IPMN. Thank you very much. Hope this video on serous cystadenoma is useful for you.